Hello, everyone. So I think we'll begin now. So my name is Vincenza Maiello, and today we'll be going over common cardiac drug toxicities. So before we begin, I just want to mention that I have nothing to disclose. So some objectives I hope to achieve today are to recognize differences and similarities in presentation, mechanisms, and diagnosis of toxic overdoses of cardiovascular drugs, to define the management of toxic overdoses of commonly used cardiovascular drugs, to discuss the methods used to minimize absorption and enhance elimination of toxic cardiovascular drug ingestions, to identify antidotes and other commonly used therapeutic interventions in patients with cardiovascular drug toxicity. So to give a little background on this discussion, these are results from the most up-to-date report of the American Association of Poison Control Centers. Results from this report show that toxicity from cardiovascular medications accounted for a large majority of fatal exposures. In 2019 alone, calcium channel blocker toxicity resulted in 109 deaths, beta blocker toxicity resulted in 36 deaths, and digoxin toxicity accounted for 19 deaths. Based on results of this report, we'll be discussing the mechanisms behind toxicity, as well as the management of toxicity with these three classes of medications. So before we begin, I just want you guys to go through this case question, and then we will refer back to it later on for application purposes. So VM is a 24-year-old female weighing 60 kilos, presenting to the emergency department after being found unresponsive by her mother. Her mother states there was an empty bottle of her diltiazem prescription next to the patient. Her labs on arrival are as follows. She's hypotensive to 80/54, bradycardic at 40 beats per minute, with a potassium of 4.5, a magnesium of 2, and a blood glucose of 130. To begin, I will first be discussing the mechanism of action of calcium channel blockers, as well as the signs and symptoms of acute toxicity. Calcium channel blockers block intracellular entry of calcium by binding L-type calcium channels located primarily in cardiac and vascular smooth muscle. There are two types of calcium channel blockers: dihydropyridines, such as amlodipine, nifedipine, or nicardipine, and non-dihydropyridines, such as verapamil or diltiazem. Dihydropyridines, as depicted on the left of this schematic, block calcium from entering the cell on vascular smooth muscle, leading to vasodilation and profound hypotension in an overdose. It also is important to note that dihydropyridines will induce an afterload reduction, which may cause a reflex tachycardia in patients. So this is something to be mindful of as well. Non-dihydropyridines, as depicted on the right of this schematic, block calcium from entering the cell on cardiac muscle, leading to a decrease in myocardial contractility and heart rate. So all in all, dihydropyridines are very effective vasodilators, but exert less influence on cardiac pacemakers and myocardial contractility. Ultimately, their effect on cardiac conduction is insignificant in therapeutic doses. Non-dihydropyridines have a greater effect on reducing cardiac conduction and contractility and produce less of an effect on vascular smooth muscle. I also want to highlight that in the event of an overdose, the selectivity of these agents may be lost. So that is something to keep in mind as well. So this is a summary of the important signs and symptoms to look out for in a calcium channel blocker overdose. So in the event of an overdose, these agents may cause profound vasodilation as well as a profound decrease in heart rate and cardiac output. Hyperglycemia is common in patients presenting with calcium channel blocker toxicity. So I want to highlight that calcium channel blockers of all subclasses reduce pancreatic insulin secretion and induce end organ insulin resistance, causing hyperglycemia. But we will delve deeper into this later on. Also, in reference to the metabolic acidosis effects, calcium channel blockers interfere with calcium-stimulated mitochondrial action and glucose catabolism. This results in lactate production and ATP hydrolysis, contributing to acidosis. Now we'll be discussing the normal mechanism of action of beta blockers, as well as the signs and symptoms of acute toxicity. So normally, norepinephrine and epinephrine bind to GS-coupled beta receptors to activate adenyl cyclase to form CAMP from ATP. When we have an increase in CAMP production, it will activate protein kinase A, leading to phosphorylation of L-type calcium channels, which will ultimately drive calcium into the cell. When we have an increased calcium entry, we have an increase in cardiac contractility, or inotropy, and an increase in heart rate, or chronotropy. Beta blockers will come in and inhibit norepinephrine and epinephrine from binding to these beta receptors, ultimately leading to a decrease in contractility and a decrease in heart rate. So just to get into the pharmacology of beta blockers, so they have differing degrees of selectivity for alpha-1, beta-1, and beta-2 adrenergic receptors, as listed in the chart here. Depending on which receptor they have the potential to block, this will lead to varying effects. So the alpha-1 receptor located on blood vessel walls is responsible for vasoconstriction. So agents that antagonize this receptor, such as labetalol or carvedilol, have the potential to exhibit vasodilation and a decrease in blood pressure. The beta-1 receptor, when stimulated, can cause an increase in heart rate and contractility. So all beta blockers that antagonize this receptor will decrease the heart rate and contractility. The beta-2 receptor is responsible for vasodilation. So agents that antagonize this receptor may cause vasoconstriction to a minimal degree. It is also important to keep in mind that in the event of an overdose, adrenergic receptor selectivity can be lost due to supertherapeutic doses. I also wanted to point out the degree of lipophilicity in these agents. The most commonly used measure of lipophilicity is the log P value. So this is the partition coefficient of a molecule between an aqueous and lipophilic phase. Generally, the higher the log P, the greater the lipophilicity. The degree of lipophilicity of these agents is important in our management of toxicity, as lipophilic agents are not as easily removed by hemodialysis or hemofiltration in the event of an overdose. I also pointed out the sodium channel blocking activity of acebutolol and propranolol, which we will go into in the next slide. So this is a summary of the important signs and symptoms to look out for in beta blocker toxicity. In the event of an overdose, I want to highlight the potential for profound vasodilation, as well as a profound decrease in heart rate and cardiac output. Sotalol, to get into specifics, has the potential to prolong the QTC interval and can lead to potential torsades de Pointes. And acebutolol and propranolol have the potential to prolong the QRS interval via sodium channel blockade. The QRS complex represents ventricular depolarization in the cardiac conduction cycle. By prolonging the QRS complex, it can result in a decreased contractility and a decreased cardiac output, which is another thing to keep in mind here. Another thing to point out is that hypoglycemia is also more common in beta blocker toxicities. In summary, the toxicologic effects between calcium channel blockers and beta blocker toxicity are relatively overlapping with few differences. Patients experiencing toxicity to these two agents will exhibit a profound decrease in chronotropy, or heart rate, and inotropy, contractility, as well as a profound decrease in blood pressure. I want to highlight that beta blockers, specifically lipid-soluble beta blockers, are more likely to precipitate CNS depression in comparison to calcium channel blockers, whose CNS depressive effects are usually secondary to hypoxia from a lack of oxygen to the brain. In addition, sodium channel blocking beta blockers, as discussed previously, have a greater potential to prolong the QRS interval. Beta blockers and calcium channel blockers have varying effects on blood glucose, with hypoglycemia being more common in beta blocker toxicity and hyperglycemia being more common in calcium channel blocker toxicity. While both have the potential to induce acidosis, it is more common in calcium channel blocker toxicity. Moving on to the treatment of calcium channel blocker and beta blocker toxicities, we will now be discussing the goals of therapy. So the goals of therapy in these patients is relatively straightforward. Ultimately, we're looking to achieve hemodynamic stability while limiting the extremely high doses of vasoactive agents needed for supportive care. In addition, we want to overcome antagonism to beta adrenergic receptors, as well as calcium channels, to counteract the effects of these agents. I want to briefly discuss the timing considerations after an overdose. The type of formulation, whether it be immediate release, sustained release, or extended release, will determine the absorption rates of these substances. It is important to take into account the rates of absorption of each of these agents, as this will determine how soon patients should present to the emergency department. Asymptomatic patients are unlikely to develop symptoms if the time frame from ingestion is greater than 6 hours for immediate release products, 8 hours for sustained release products, 12 hours for sotalol, 18 hours for modified release products other than verapamil, and 24 hours for modified release verapamil. This is not to say that these asymptomatic patients do not require monitoring in the event of an overdose, as effects do vary based on individual characteristics. So moving on to the initial management and supportive measures, first and foremost, we want to maintain airway and ventilation in these patients. Fluid resuscitation is also essential to correct vasodilation and low cardiac filling pressures. Continuous cardiac monitoring is also pertinent. Vasopressors and inotrope use is also essential to counteract the decrease in heart rate and hypotension. Pacer pad placement is also important in the event a patient requires transcutaneous pacing in profound bradycardia. Now we'll be discussing decontamination and enhanced elimination methods for toxicity of these patients. So controversy exists regarding the utility of gastrointestinal decontamination in early intervention patients. It should not take precedence over resuscitation and should be avoided in unstable patients. So typical decontamination methods, however, include activated charcoal, whole bowel irrigation, or gastric lavage. Conventional methods like urinary alkalization, hemodialysis, or hemofiltration are generally ineffective in calcium channel blocker or beta blocker toxicity, as they have a large volume of distribution, high lipophilicity, high affinity to plasma proteins, and extensive first pass metabolism. These characteristics render these agents resistant to these measures, as they would not be properly eliminated via these mechanisms. So moving on to the use of activated charcoal, I just want to point out the important differences between charcoal and activated charcoal. So activated charcoal is more porous, has a higher surface area, and is purer than regular charcoal, making it useful in decontamination measures. Activated charcoal exerts its effect by adsorbing ingested toxins within the GI tract, preventing the systemic absorption of that toxin. So it's typically recommended within 1 to 2 hours after ingestion. It may, however, still offer benefit if administered outside of that time frame, as shown from the results of 2 controlled volunteer studies. So in a study involving amlodipine, administration of activated charcoal decreased the area under the curve, or the absorption, by approximately 99% immediately after ingestion and by 49% when administered 2 hours after ingestion. In a study including sustained release verapamil, administration of activated charcoal decreased the absorption by about 32% when administered 4 hours after ingestion. So 32% and 49% is not bad considering the delayed administration. However, better outcomes are associated with earlier intervention. Also, I pointed out the contraindications such as altered mental state or unprotected airway. So patients that are exhibiting altered mentation or have an unprotected airway may be at a higher risk of pulmonary aspiration. Therefore, an adequate airway assessment must take place before the administration of activated charcoal. I've also included the dosing here for your reference. So adults typically get a single dose of 1 gram per kilo by mouth, and pediatric patients get either 10 to 25 grams if they're less than 1 year old, and 25 to 50 grams if they're 1 to 2. So some additional decontamination strategies. So gastric lavage is indicated for patients who present within 1 to 2 hours of an overdose. There is a theoretical concern for increasing vagal tone and worsening bradycardia in these patients. So profound bradycardia, cardiac arrest, and asystole may be precipitated by lavage in poisonings with calcium channel blockers or beta blockers. So this is something to be mindful of as well. Whole bowel irrigation is usually considered in sustained release preparation, and it has been commonly used, especially in sustained release calcium channel blocker formulations. So moving on to the role of IV calcium. So it's typically indicated for hypotension. So the rationale behind calcium administration is that increased extracellular concentration will promote calcium influx via the unblocked L-type calcium channels. However, it is important to note that responses are variable and suboptimal with severe toxicity. Calcium salts such as calcium chloride and calcium gluconate are taught as the first-line agents for calcium channel blocker overdoses. Calcium administration, however, may also help with hypotension from beta blocker toxicity as well. It is important to be mindful of the potential for calciphylaxis with IV calcium administration, which can cause calcification of arterioles and small arteries, leading to hypoperfusion and eventually multi-organ failure. So that's something to be mindful of going forward. So generally, we give IV calcium salts until the serum calcium level is on the higher end of normal. Calcium gluconate has a lot less elemental calcium than chloride, thus correlating to the higher dosing of calcium gluconate in comparison to calcium chloride as depicted in the chart. Calcium gluconate, however, is associated with less extravasation risk and can be given both peripherally and centrally. Peripheral administration is much more practical in an emergent situation, which is why calcium gluconate is more widely used. Continuous IV calcium infusions don't likely have any benefit once the serum calcium levels are maximized with bolus doses. So calcium may improve hypotension and conduction disturbances, but is less effective in the management of bradycardia. We should also be mindful to administer calcium over 5 minutes, not to exceed a max rate of 200 milligrams per minute, as faster administration can cause hypotension, atrioventricular dissociation, and ventricular fibrillation. Now moving on to the role of atropine in the management of these toxicities. So atropine is currently recommended as a standard advanced cardiac life support measure for symptomatic bradycardia. Although this can be administered following poisoning with these agents, it is unlikely to have a significant or persisting effect on heart rate. All in all, atropine may reverse bradycardia, but its effect is often short-lived, so its long-term use is often not practical, hence its use in conjunction with other agents. I did include the dosing in the slide for your reference. I do want to highlight that the maximum dose is 3 milligrams, so we want to be careful and make sure that we don't exceed that dose, as this can result in the development of anticholinergic toxicity and delirium. In addition, the anticholinergic effects may lead to a decrease in GI motility, which may influence gastrointestinal decontamination as well. Moving on to the role of glucagon in the management of these toxicities. So glucagon is secreted from alpha cells of the pancreas, and it acts through activation of adenylate cyclase via G proteins, resulting in a positive chronotropic and inotropic effect. Its primary benefit is seen in beta blocker toxicity, as hypoglycemia is more prevalent in these patients. Glucagon is expensive, so if the repeat bolus does not work, you would not recommend the continuous infusion, as there is no purported benefit. We should also be mindful of the nausea vomiting effects of glucagon. We could consider giving an antiemetic prior to initiation of this, and also slow administration, typically over 3 to 5 minutes, may lessen the effects of the nausea and vomiting. It's also important to keep in mind that glucagon is expensive. So it comes as a 1 milligram kit, which is approximately $266 according to Cardinal. So one bolus dose for this indication at the lowest dose of 3 would be about $1,000. So this is something to keep in mind in practice as well. So the following agents are supportive treatments usually initiated in conjunction with other therapies to increase blood pressure and cardiac contractility in these patients. Common vasopressors used are norepinephrine or epinephrine. Both norepinephrine and epinephrine increase inotropy and cause vasoconstriction. Epinephrine may be preferred, as norepinephrine has a greater effect on vasoconstriction rather than inotropy in comparison to epinephrine. Inotropic agents such as dobutamine or milrinone have been used and may be beneficial in increasing the cardiac output. However, they should not be used alone due to the fact that they have a vasodilatory risk, which could be deleterious in these patients presenting with hypotension. Methylene blue has also been used as well. Its mechanism is via inhibition of nitric oxide synthesis, which will lead to an increase in the systemic vascular resistance. So this may be beneficial in patients with profound hypotension. Sodium bicarbonate may be beneficial in patients exhibiting metabolic acidosis and QRS prolongation by reversing the acidotic state, as well as antagonizing sodium channel blockade induced by sodium channel blocking beta blockers. ECMO may also be used to increase oxygenation to end organs that may be hypoperfused in the setting of shock. Now we'll be discussing the role and potential benefit of high-dose insulin euglycemic therapy in the management of beta blocker and calcium channel blocker overdose. So the metabolic effects of calcium channel blockers and beta blocker toxicities is important in explaining the benefit of insulin in this setting. So calcium channel blockers will impair insulin release from pancreatic isolate beta cells that depend on calcium influx via an L-type calcium channel. It inhibits calcium-dependent mitochondrial activity required for glucose catabolism as well. Incidence of hyperglycemia is more common in calcium channel blocker toxicity, but the effects on glucose are variable. Beta blocker toxicity exerts its metabolic effects via blockade of beta-2 adrenoreceptors, resulting in impaired lipolysis, glycogenolysis, and insulin release. So hypoglycemia is more common here, but the effects are variable. So all in all, calcium channel blocker and beta blocker toxicity results in circulatory shock and stress on the myocardium, which will lead to a switch of the cellular metabolism from free fatty acids to carbohydrates. So by inhibiting glucose catabolism and switching the cellular metabolism from free fatty acids to carbs, the myocardial cells will require more glucose to function properly. Insulin will come in and improve glucose utilization. So high-dose insulin therapy is beneficial via its direct positive inotropic effects to increase cardiac output. Insulin can significantly improve myocardial contractility when standard therapies have failed. Insulin has inotropic activity and allows the myocardium to utilize energy in the form of carbohydrates more efficiently. The result is increased myocardial contractility and improvement of perfusion via increased cardiac output. It is given at approximately 10 times the regular insulin dosing recommended in diabetic ketoacidosis and hyperosmolar hyperglycemic state. So it's dosed at a 1 unit per kilo IV bolus and a 0.5 to 1 unit per kilo per hour continuous infusion. So due to the high dosing, it can lead to the challenge of hypoglycemia and hypokalemia due to the intracellular shift of potassium. It's predominantly beneficial in calcium channel blocker toxicity, and contractility increase is typically seen within 15 to 60 minutes of initiation. So when initiating high-dose insulin therapy, we want to ensure that the potassium is greater than 3 and to ensure that the glucose is greater than or equal to 200. If they're not within range, we should supplement accordingly. So we typically initiate a 50% dextrose infusion, titrating to maintain a blood glucose of greater than 200 milligrams per deciliter and to optimal clinical response. When we're ready to discontinue insulin therapy, we taper down in conjunction with the dextrose every 2 hours. It is important to continue dextrose for at least 1 additional hour after discontinuation, as insulin has a longer half-life than dextrose, which may precipitate hypoglycemia if it is shut off prematurely. So now coming back to the case question, VM is a 24-year-old female weighing 60 kilos, presenting to the emergency department after being found unresponsive by her mother. Her mother states there was an empty bottle of her diltiazem prescription next to the patient. She is currently receiving hyperinsulinemia euglycemia therapy with a continuous infusion of regular insulin in addition to epinephrine. Her labs and vitals on arrival are as follows. Her blood pressure is 80/54, her heart rate is 40 beats per minute, her potassium level is 4.5, her magnesium is at 2, and her blood glucose is 130. What would you recommend doing next for this patient? So I'll give everyone a minute to respond. Yes, so we would supplement dextrose here. So when initiating high-dose insulin therapy, we want to ensure that the potassium is greater than 3 and ensure that the glucose is greater than 200. So in this scenario, potassium is within range and dextrose here is less than 200 at 130. So we'd supplement the dextrose here to prevent hypoglycemia. Now I want to briefly discuss some considerations we as pharmacists should take into account. So we want to monitor mean arterial pressures and heart rate to assess clinical response. If the patient's vitals are improving, we can potentially taper down on insulin. It is especially important to monitor our electrolytes, in particular potassium, due to insulin causing an intracellular shift of potassium, leading to hypokalemia. It's also pertinent to monitor glucose every 15 minutes until the patient is stable, and then every 30 minutes thereafter. We should also be providing continuous glucose monitoring every 30 to 60 minutes for 6 hours, even after discontinuation of the insulin. It is also important to monitor the electrolytes, especially potassium, due to the insulin causing an intracellular shift of potassium. leading to hypokalemia. Hypokalemia can precipitate further arrhythmias, complicating the treatment course as well. So some preparation and administration considerations. So due to the high insulin drip rates associated with this indication, it is important to be mindful of the high utilization. So in the event of an overdose, we may see more bags given more frequently due to this. The adverse effects that we'd want to be mindful of, again, are hypoglycemia and hypokalemia. So there is an existing institutional power plan for high-dose insulin therapy for calcium channel blocker and beta blocker overdose, and I attached it here for your reference and perusal. In reference to the previous slide, I wanted to point out that the concentration of the insulin bags are much higher than in DKA and HHS. The concentration is 10 units per milliliter for calcium channel blocker and beta blocker overdose, whereas it is 1 unit per milliliter for DKA or HHS. So due to the higher rates, we are giving higher volumes to account for the higher utilization. So this is something to be mindful of, especially during order entry. So this is a result of a prospective observational study discussing the relative safety of high-dose insulin therapy. So information was collected prospectively for 7 patients with severe calcium channel blocker toxicity defined as systolic blood pressure of less than or equal to 90. The mean blood glucose at the time of presentation was 210, with 1 patient experiencing a hypoglycemic event with a blood glucose of 43. So only 3 patients in the study received a loading dose of 1 unit per kilo of regular insulin, and everyone received an insulin infusion of 0.5 to 2 units per kilo per hour. The results show that all patients experienced a significant sustained rise in the systolic blood pressure during the first hour of high-dose insulin therapy. The systolic blood pressure did not increase significantly in 4 patients who did not receive the insulin loading dose, which signifies the benefit of the loading dose. The study concludes that high-dose insulin is a safe intervention with maximal efficacy being obtained when administered in conjunction with conventional therapy early in the course of severe calcium channel blocker poisoning. So now I have an assessment question that I want you all to participate in. So the main benefit of high-dose insulin euglycemic therapy in calcium channel blocker, beta blocker toxicity is its increase in cardiac inotropy. True or false? So yes, the answer here is true. So insulin has inotropic activity due to the fact that it allows the myocardium to utilize energy in the form of carbohydrates more efficiently. The result is increased myocardial contractility and improvement of perfusion via increased cardiac output. Now we'll be discussing the role of intravenous lipid emulsion in the management of these toxicities. So intravenous lipid emulsion is an oil and water emulsion that creates a lipid phase within the plasma and pulls a lipid-soluble drug into the lipid phase in the blood. Lipid emulsion infusion can sequester intensely lipophilic drugs like verapamil and diltiazem and thus reduce their volume of distribution. It also increases fatty acid transport, causing an increase in myocardial energy utilization, leading to an increase in cardiac calcium levels and an ultimate increase in inotropy. Its role is more established for local anesthetic toxicity with limited evidence in calcium channel blocker or beta blocker toxicity. However, results from limited case series have demonstrated benefit as last line. So it's typically indicated in refractory hypotension with lipid-soluble drugs. I do want to point out here that the dose used in calcium channel blocker or beta blocker toxicity is 2.5 times that of the nutritional dose seen in TPN administrations. So that is another thing to keep in mind when verifying these orders. Also, lipid emulsions can interfere with complete metabolic panels due to its elevations in triglycerides and pancreatic enzymes. So it is pertinent to monitor serum triglyceride levels and metabolic panels in these patients. So I've included some concerns associated with intravenous lipid emulsion therapy. So there are some reporting bias concerns relating to the studies conducted on these therapies, as most of these studies are on case reports. I've also included the results of a study done on rats showing that administration of lipid emulsion for the highly lipophilic amitriptyline in overdose resulted in worsening outcomes and hemodynamics. It is, however, more pertinent to point out that it was shown to delay the effect of epinephrine, which is not something we'd want to see in patients requiring vasopressor support. Intravenous lipid emulsion was also shown to increase fat deposition, leading to clotting of ECMO circuits, which is a negative outcome in patients requiring ECMO. The role and efficacy of lipid emulsion therapy in calcium channel blocker toxicity are mostly based on animal studies and case reports, and is therefore recommended only in refractory shock or severe toxicity unresponsive to conventional treatments. So in summary, when patients present with beta blocker or calcium channel blocker overdose, we want to protect the airway, initiate fluid resuscitation, and potentially initiate activated charcoal, gastric lavage, or whole bowel irrigation if indicated. If significant hemodynamic instability is present, we can initiate glucagon in suspected beta blocker poisoning or IV calcium and calcium channel blocker poisoning, in addition to atropine, sodium bicarbonate if acidosis or QRS widening is present, vasopressors and inotropes to increase the heart rate and contractility, or potentially methylene blue for hypotensive patients. Normally, we would continue pressors until the insulin takes effect and then slowly taper down according to the clinical response. Lipid emulsion therapy, or ECMO, again, may be initiated in the setting of severe refractory shock, unresponsive to the above measures. So that concludes our segment on calcium channel blocker and beta blocker toxicities. Now we will be moving on to discuss the management of digoxin toxicity. So to go into the mechanism of action, this is a depiction of the myocardial cell that digoxin exerts its effects on. The sodium potassium ATPase pump normally causes sodium to leave cells and potassium to enter cells. Digoxin will come in and inhibit active transport of sodium and potassium across the cell membrane during repolarization by binding to the sodium potassium ATPase pump. By blocking this mechanism, digoxin will shift potassium extracellularly, increasing serum potassium levels. It will also increase intracellular sodium, which will drive an influx of calcium in the heart, causing an increase in myocardial contractility. Digoxin is a positive inotropic and negative chronotropic drug, meaning it will increase the force of contraction while decreasing the heart rate via AV nodal inhibition. It's also important to keep in mind the half-life of digoxin at 38 hours. I just want to point out that the effect does vary depending on age, renal, and cardiac function. So some risk factors for digoxin toxicity. So digoxin is primarily eliminated by the kidneys. So patients with renal impairment are at an increased risk of digoxin toxicity as they will not properly eliminate the drug. Age is also a risk factor as elderly patients are more likely to have decreased renal function and likely to be taking potentially interacting concomitant medications. So various drugs alter the renal excretion or P-glycoprotein activity of digoxin. So for example, amiodarone, verapamil, or diltiazem may increase the serum concentration of digoxin due to PGP inhibition. Fluid loss or poor fluid intake can also lead to electrolyte imbalances such as hypokalemia, hypercalcemia, or hypomagnesemia. These electrolyte imbalances can increase the sensitivity to digoxin's effects as well. So now, just to jump right into another assessment question, I'd like you all to participate in this. So which laboratory abnormalities are associated with increased risk of digoxin toxicity? Select all that apply. So yes, the answer here would be 2, 3, and 4. So it is pertinent again to monitor laboratory values in patients with digoxin toxicity. So in states of hypokalemia, digoxin toxicity is actually worsened because digoxin normally binds to the ATPase pump on the same site as potassium. When potassium levels are low, digoxin can more easily bind to the ATPase pump, exerting the inhibitory effect. Hypomagnesemia can potentiate hypokalemia as magnesium is needed to facilitate absorption of potassium. In regard to calcium, the endpoint of digoxin's effect is to open the membrane calcium channels, resulting in an increased calcium influx into cells. So when the calcium levels are high in the setting of digoxin toxicity, the result is an increase in calcium influx and enhanced toxicity. So these electrolyte imbalances can increase the sensitivity to digoxin's effects. So some more electrolyte considerations to be mindful of. Digoxin toxicity causes hyperkalemia due to its effect on the sodium potassium ATPase pump. Hyperkalemia is a poor prognostic sign. Actually, among one series of patients with acute digoxin intoxication prior to the availability of Digifab, all patients with potassium levels above 5.5 milliequivalents died. So that is something to keep in mind, as well as levels greater than 5.5 are associated with 100% mortality. Hypokalemia, on the other hand, is a more favorable prognostic sign in comparison to hyperkalemia, but it doesn't guarantee a good outcome, as hypokalemia may exacerbate digoxin toxicity. It is important to treat this aggressively to avoid further dysrhythmias. So ideally, we'd want to keep potassium within a range of 4 to 5. In addition, we should always correct magnesium first. If the magnesium is low, because magnesium repletion will help to increase absorption of potassium in a patient presenting with hypokalemia. So we should also keep in mind that we should use magnesium cautiously, as it could potentiate further bradycardia or heart block, especially in patients with renal dysfunction. So there are varying symptoms of digoxin toxicity based on whether the patient is presenting with an acute or chronic toxicity. So primary signs of toxicity are bradydysrhythmias. While there is much overlap between symptoms and acute versus chronic toxicity, I do want to point out that there are more neurological symptoms associated with chronic toxicity, such as photosensitivity and vision changes. Hyperkalemia is primarily seen in acute toxicity, but can be seen in chronic toxicity as well. Hypokalemia also may occur in chronic toxicity, especially in patients taking concomitant diuretic therapy. So the available treatment for digoxin toxicity is digoxin immune fab. So when administered to the intoxicated patient, Digifab binds to the molecules of digoxin, reducing free digoxin levels, which results in a decrease of free digoxin binding to the sodium potassium ATPase pump, thereby reducing the cardiotoxic effects of digoxin. So the therapeutic range of digoxin has historically been 0.5 to 2 nanograms per milliliter, with toxicity beginning at a level of greater than 2. So digoxin requires over 6 hours to distribute into the tissues after oral intake. Only post-distribution levels will reflect the severity of intoxication and help calculate the dose of Digifab. It is important to measure serum digoxin before Digifab administration, because post-administration levels do not correlate to clinical toxicity. So lab values take into consideration both unbound and bound serum digoxin levels. And once the Digifab is administered, serum digoxin concentrations are unreliable, as this takes into account both the bound and unbound digoxin. So only unbound digoxin here is helpful in the clinical estimation. So these are the indications for administration of Digifab. I would like to differentiate between the acute versus chronic ingestions. So acute ingestions are known suicidal or accidental ingestion of fatal doses of 10 milligrams or more in healthy adults, 4 milligrams or 0.1 milligram per kilogram or more in healthy children, or an amount that results in a steady state concentration of greater than 10. Chronic ingestions are those with a serum level of greater than 6 in adults or 4 in children. Digifab is also indicated in patients with severe ventricular arrhythmias, progressive bradycardia, second or third degree heart block unresponsive to atropine, or serum potassium levels greater than 5.5. So now, just to jump into the dosing of Digifab, the dosing does vary according to the patient's clinical condition and the amount of digoxin to be neutralized. So the dosing here reflects whether or not the patient is presenting with an acute versus chronic ingestion, and whether or not we know the amount ingested or the serum concentration. So in an acute ingestion with an unknown amount ingested, we would initiate 20 vials of Digifab. In an acute ingestion with a known amount ingested, we would follow the formula on the left-hand side. Please note that the amount ingested in milligrams is multiplied by the bioavailability of the formulation. So there is an 80% bioavailability with the tablets versus 100% bioavailability with the capsules. So the formulation type is something to keep in mind here. In a chronic ingestion with an unknown concentration, we would initiate 6 vials in adults and children greater than or equal to 20 kilograms. and 1 vial in infants and children less than 20 kilos. In a chronic ingestion with a known concentration, we would follow the formula listed here to determine the number of vials. There are available calculators on the DigiFab website to help facilitate the dosing calculations for these patients. The reference for this is available in the footer of this slide for your perusal. So moving on to the preparation and administration of DigiFab. So it's normally reconstituted with 4 milliliters of sterile water and then added to the appropriate sodium chloride bag. We would use it immediately after reconstitution, and we can also store it in the refrigerator for up to 4 hours. So the stability is something to keep in mind for our practice. So these are some of the most common adverse effects associated with DigiFab. Digoxin will primarily increase contractility of the heart, and if its effects are reversed, patients with congestive heart failure will have reduced cardiac output. In addition, a rapid shift of potassium back into the cell can occur when digoxin toxicity is reversed by DigiFab, so hypokalemia is common. Serum potassium should be followed closely, and supplementation should be given cautiously. Also, reversal of the negative chronotropic effects of digoxin can also lead to worsening atrial fibrillation as well. So just to dive into the DigiFab literature, so in 2 studies by Antman et al. And Schaefer et al., patients were administered DigiFab in the setting of severe digoxin toxicity. I've included the patient characteristics and statistics for your perusal. Results of both studies indicate a positive response to DigiFab administration, and the majority of patients in both studies sustained a mortality benefit as well as an improvement in cardiotoxicity. So now I want to discuss the role of calcium in digoxin toxicity. So according to the stone heart theory, administration of calcium in the setting of digoxin toxicity may lead to an irreversible non-contractile state of the heart. Although calcium is used to antagonize cardiac effects of potassium in hyperkalemic patients, it is currently considered contraindicated in digoxin toxicity due to the risk of serious arrhythmias. This theory raises controversy with use of calcium for this indication. So the question of the stone heart effect was investigated in a study conducted by Levine et al. That reviewed patients with digoxin toxicity from 1989 through 2005. Out of 2,000 patients who had elevated digoxin levels, 161 patients were documented to have digoxin toxicity, with 23 patients receiving IV calcium. The results showed that there was no association between calcium administration and death in the population. And in addition, there was no case of any potentially life-threatening dysrhythmias within 4 hours after calcium administration. Ultimately, the study found that there was no evidence that associated digoxin toxicity and calcium with the myths of stone heart. The constant back and forth, however, of the truth behind stone heart with regards to digoxin toxicity and calcium is still a controversial topic. Despite some data showing no risk, treatment of hyperkalemia with intravenous calcium in patients with digoxin toxicity should still be initiated with caution due to the potential risk of increased myocardial contraction and overall risk of arrhythmia. So DigiFab administration thus remains the primary treatment in reversal of hyperkalemia associated with digoxin toxicity. So to conclude, we as pharmacists play an essential role in the identification and management of these toxicities. Presentation of these toxicities are often overlapping with key differences. It is important to know that upon presentation, supportive treatment of hypotension and bradycardia, as well as high-dose insulin therapy, is key in the management of calcium channel blocker or beta blocker overdose, and reversal of digoxin's pro-rhythmic properties is achieved via administration of DigiFab. I've included the number to poison control for your reference, as they may provide further insight in the management of these toxicities. So that concludes our discussion today. Thank you all for coming. Does anyone have any questions? Okay, so it looks like there's no questions in the chat box. So that will conclude our discussion for today. Thank you all for coming. I hope this was informative and applicable to your practice.